Thank you very much. It's a big pleasure and honor to be here to present. I will today not talk about the health system in China, but some lessons from Sweden. There are both, I think, some issues and also some successes in the health reforms that have been going on in Sweden. And I think today we focus much on the issues and problems and challenges that we face. But I think there is a convergent observation, I think, from health systems all over the world, something which is very positive. And that is that life expectancies are increasing worldwide, not only in Europe or in the US, but even more so in low and middle income countries. This is because of better immunization programs for children, better child health, and also better control of infectious diseases, communicable diseases. But I think this also leads to what is the topic of one of the sub-forums, that we have an increasing population of elderly. And that also leads to the second topic of a sub-forum here, that we will see more of chronic conditions and complex health conditions. And that in turn leads to the sub-forum today, challenges for universal health coverage. Because as previous presenters talked about, it leads to issues with cost containment, which is a challenge for health systems in all countries. So some of the obvious differences, Sweden to other countries. Sweden is a country with a small population, just less than half of Shanghai's population, and the area of Sweden is quite large. I mean, it's the third largest country in Europe, in European Union. You see here Stockholm, but 84%, the vast majority, live in urban areas. They are concentrated to a few regions in Sweden. So since Sweden is quite covers a large area, that means that people in the rural areas sometimes have quite a distance to go to health facilities to reach a hospital. It could be 300, 400 kilometers to reach a hospital for a delivery, for example. Another feature in Sweden is that we have a high percentage of the population born outside Sweden. Maybe you've seen on TV in recent days the riots in Husby outside Stockholm. And there are some areas outside Stockholm where we have a concentration, maybe 85, 90% of the population in those communities are born outside Sweden. Even in my hometown, 1/3 of the adult population were born outside Sweden. So we receive about 100,000 asylum seekers every year in Sweden. So that also is a challenge to the health system, because many of these people, they come from war-torn countries, they have a complex and difficult health situation. So that presents extra challenges to the health system. And yeah, there's one city outside Stockholm that received more Iraqi refugees than the whole of the United States. Actually, but as mentioned, people live longer, and this is in Sweden also the case. Life expectancies has increased, and they seem to continue to increase. And as we can see, the difference between men and women is decreasing in Sweden. One reason for this is that smoking among men is quite low. Actually, in Sweden, there are more women than men smoking. And this has made an impact now. Chronic obstructive pulmonary disease is more common among women than among men. And also lung cancer is increasing more among women than men. So, and also the demographic profile of Sweden is changing. It's no longer a pyramid, it's more a pillar. And today we have quite a few centenarians, 100 years old in Sweden, and that's a group that's increasing rapidly. And we can see that from those who are just about to retire, 65 or just under 65, there are almost as many men as women surviving, and that's a group, the above 65, today it's 20% of the population. I think that's where China is heading the next few years, but this is already the case in Sweden, and that group will continue to increase over the years to come. Fertility levels within the European Union, fertility levels are in general below replacement levels, but Sweden is one of the countries with relatively high fertility. And this is, I think, because of generous maternity leave and child support in Sweden. So the fertility patterns have really changed. I mean, it used to be high fertility levels in Southern Europe and low in Northern Europe, but now it's rather the opposite. And if we look at health statistics, Sweden seems to be quite successful. I think looking at undefined mortality and maternal mortality, I think these are very good indicators because it says something about accessibility, utilization of health services, but also of the quality of health services. Because these are really hospital and healthcare related outcomes. And we can see that Sweden have among the best. But Sweden is also affected by this global obesity epidemic, which will have a price in health and affect healthcare utilization in the future. It's increased over the years, and the proportion of really classified as fat is somewhat higher among women than men. Some of the characteristics, it's important to understand in the Swedish health system that we have 3 democratically elected levels. We have the national level, then we have county councils. The counties in Sweden are approximately the size of Chinese counties, and healthcare in Sweden is decentralized. It's organized at the county level. That's one similarity with China, actually. And municipalities, they have part of the health system. So the county councils, they are autonomous political entities. They have a politically elected leadership, and they can tax the population within the county. And they are primarily concerned with healthcare, providing hospital care and primary health care. But social care, care for the elderly, is handled by the municipalities. Also outpatient psychiatric care is handled by the municipalities. Municipalities also have taxation rights and a politically elected leadership. So this is, we talked before about health expenditure in the US. This is a comparison between some of the big European countries and Sweden. And we can see that those who have a tax-based health system seems to have a bit lower total cost of healthcare. UK and Sweden have tax-based healthcare financing. Germany and France have social insurance. And the US is the outlier, of course, with very high costs. But I think the interesting thing is that when we look at the government expenditure in the US, it's actually higher than European countries. That's really interesting to think about. Yes, per capita expenditure is higher. Government per capita, it's really surprising. And yeah, in dollars, yes, yeah. And in Sweden, the drivers between health reform, I think in 1980s we had the Reagan-Thatcher political era with liberalization and political swings. And health reform started not only in China but also in Sweden and many other countries in the 1980s, shift to more market-oriented reforms. And the drivers behind the reforms in Sweden in the 1990s, one was the aging population, another one was a growing population with the asylum seekers coming in with very complex health conditions. increasing prevalence of obesity and health conditions related to that, which also put pressure on the health system, and overall changing morbidity patterns with more chronic and complex conditions among the elderly. And also new drugs and new procedures which were introduced and increasing the cost in the system. So it was necessary to control costs and to really make the health system viable. So the key strategies in health reforms in Sweden have been these. I mean, reduce the cost of inpatient hospital care by reducing lengths of stays, having more efficient care, shorter lengths of stays for some of the procedures. And also to shift services away from costly inpatient hospital care to more outpatient-based care. And also to use primary health care wherever applicable. And when it comes to drugs and pharmaceuticals, it was to strengthen the centralized control. Otherwise, the health system in Sweden is decentralized. And the trend has been rather to open up for more private providers, etc. But when it comes to pharmaceuticals, the tendency has been to have stronger central control over, also over allowing new drugs. I mean, really checking that they are more cost effective and negotiating prices with the producers also. And also, as was mentioned by the previous presenters, I mean, reforming provider payment systems to provide incentives for efficiency and quality in services. And some of the county council, I mean, Sweden has a decentralized system, and it means that different county councils have different strategies and different approaches. But especially in Stockholm, there's been introduction of more choice and allowing private competition. And finally, using financial tools to manage the sector rather than administrative. So in 2005, there was introduced something was called the Care Guarantee. It's called 07-1990. And this was because there had been a problem in Sweden with waiting queues, that people had to wait for long periods to get, for example, hip and knee surgeries. And this meant that all patients should be able to contact primary care within the first day of a health problem, and that all patients should be able to get an appointment with the doctor within 7 days. And when they need a specialist, they should be they should get an appointment with a specialist within 90 days. And if they then need treatment or a procedure, that should be done within another 90 days. And if the county could not provide these services, then the patient could go to another county, or they could even go abroad to get and the home county would have to pay for that. So there are limits in Sweden to the cost to the patient. And there's a registration fee when you visit a family doctor or polyclinic. It's something like 150 to 300 Swedish crowns. That's about, how much is that in dollars? That's $25 to, let's say, $25 to $50. And it's a little bit higher to visit a specialist. Inpatient care, if you're 18 or less, it's free of charge. You don't have to pay anything. If you're above 18, then you pay a nominal fee per day. I mean, that's to pay for the bed fee or cost of food that's provided. But there's no charge for treatment or for drugs within the treatment. And then there's also a ceiling amount. Within a running 12 months cycle, there's a ceiling to how much. Oh, sorry. Okay, I'll go with. When we talk about the hospital reimbursement systems, in the early 1990s, DRGs were introduced in Sweden as a payment system. it was used in hospital, but it was abandoned because of it resulted in deceitful practices. It's come back again. It's back again, but there are many issues related to DRGs. And you mentioned also bundle payment, and I think in Sweden was one of the first countries to implement bundle payment. And there's a study quite recently by Harvard and Karolinska on the effects of using bundle payments. And this was done on hip and knee surgery in Stockholm. And there they introduced a unit price of 56,300. It's how much is that? About $9,000, which would cover a case of surgery for an uncomplicated hip or knee surgery. It would include diagnosis, surgery, rehabilitation, prosthesis, and follow-up. And it included a 5-year guarantee. So if you have to come back, then the hospital would have to cover that also within a 5-year period. So this was initiated in 2009, and there was a free establishment right for providers. So it meant competition between private and public providers. And it was a free choice of caregivers for the patients. And there was a web service set up informing about outcome data for the providers. Yeah. So this has been evaluated. It's a preliminary evaluation, but it looks quite positive. I mean, one of the findings was that there were waiting queues before this was introduced, but when this happened, then there was a 20% increase in the first year. Then it dropped by 4%. But after this was introduced, there were no waiting queues anymore. And the volume increased by 16%. And yet the cost for the Stockholm County Council was reduced by 4%. So it seems there are some positive effects of this. But again, I mean, this is for uncomplicated cases, and it's a straight procedure. So I think when we see today, we have more and more of chronic conditions, of elderly patients with multiple diagnoses, etc. I think this is not the payment system that you can use for continuous care. So I think we still have this challenge, I mean, to develop another payment system for. And there is a risk, I think, also of cream skimming, that hospitals will tend to take these easy cases, and of course they can improve efficiency for those. But and we can see here, this is a chart showing, if you see Sweden there, today Sweden has among the lowest number of hospital beds of all OECD countries. That's a result of these shifts from inpatient services to outpatient services and reducing length of stays. So there was a reduction from 1990 to 2005. You can see the reduction in Sweden was more than in most other countries. And today it's only Turkey and Mexico who have fewer hospital beds. And that may be for different reasons. It's okay. But there are wide differences among the OECD countries, as you can see. But this is one of the results of the policies, I mean, or the reform. And for some diagnoses, it can be a good thing. Yeah, thanks. We have, for example, myocardial infarction. You can see the Nordic countries, Sweden, Denmark, Norway, have the shortest lengths of stay following acute myocardial infarction. And when we look at survival, 30-day survival after acute myocardial infarction, we see that the same countries are in the top also. We have the best survival data for those. You can see Denmark, Norway, Sweden have the lowest case fatality rates within 30 days. And we can see that these columns show that it has improved during the years when the inpatient length of stay was shortened. It improved also the survival. And that's because, of course, staying in hospital is not good for sick people. I mean, it's a risk of infections, hospital infections, and many other things. So if we can do it more effectively, it's also better for the health of the patients. Here's another. Asthma is an indicator of how primary care functions in a country. If you have good primary care, then asthma patients should not be admitted as inpatients. But we can see here also that there are huge differences among OECD countries. We see for the United States, you have very high admission rates for asthma patients, which is not good for the health of the patients also. It costs money and also not good. This is also chronic obstructive pulmonary disease, and this is the same thing. They should be treated on outpatient basis or in primary care. But when we have high hospital admissions, that's scope for improving efficiency and at the same time improving health. Okay. Caesarean sections is another thing. We know that here in China, Caesarean section rate is quite high. And that also contributes to costs and to long hospital stays. It's high in all countries of the world, but there was a recent study showing that the risk of asthma in children increases with Caesarean delivery. So it also has health impact both for the mother and the child. And I want to show this one. This is something about the issues in Sweden that we have. Maybe it's a bit difficult, but if you have, these are the county councils in Sweden. Each bar represents the county councils, and then they are grouped according to the age of the patients. And this is for women who receive outpatient-based psychiatric care, that they receive psychotherapy, for example. And we can see that there are vast differences, not only across the counties in Sweden, but also for the age groups. So we see that the higher the age of the woman, the less chance she has of getting psychotherapy, although we know that it's very good for women at high age to have psychotherapy. Many have social isolation, etc., and they need someone to talk to. But if you look at this figure, this shows medical treatment of minor psychiatric diagnosis. And here we see the opposite pattern, that it's the old women who get benzodiazepines, although they are those who least tolerate. So we have problems to address in Sweden as well. This is not good, and I think doctors know that, but yeah. So one of the strategies is in Sweden has been to control the cost of drugs. And if we look at this, the increase in per capita pharmaceutical expenditure in Sweden has been quite low. It has been possible to control the cost of drugs. And this has been done by different approaches. One has been, this one shows the benefits, the public subsidies for drugs. And you see the lowest line here, it shows the cost of inpatient drugs for inpatients. And as you can see, it did not increase very much in this period, 1990 to 2000. And the reason was that hospitals are not compensated for, they are paid and the cost of drugs is included, so they have very strong incentive to use generic drugs and low-cost drugs. But the big increase was in outpatient prescription drugs. This was a big increase in this period from 1990 to 2000. There was, at that time, about 20% of the total healthcare cost was for drugs, and it was outpatient prescription drugs. And this was also a consequence of the shift from inpatient care to outpatient care. So it was an expected consequence, you can say. But after that, much has been done to control the cost escalation. And today, the cost of drugs is less than 10% of the total healthcare cost. I think actually this year it will be less than 8%. And this is because there's an agency in Sweden, a government agency, which negotiates with the drug producers about the cost, and they also keep a close check on, they don't allow benefits, medical benefits for drugs if the producer cannot show that it's better than existing drugs. And many of the new drugs that are introduced are more expensive, but they have not proven to be better than existing drugs. So that's okay. I think I'll stop here. I'm done. Thank you.